but I will focus mainly on the investigation, but not too much on drug treatment, because tomorrow we have a talk. So this is the course tomorrow. If any one of you still want to register, I think it's still open, that you can join the course in the online tomorrow. This is the link. If you click the link on neuro.org.my, EME is Epilepsy Made Easy 2020, then you will be able to join the link, the course for epilepsy tomorrow. And this course is a one whole day course from morning till afternoon. It covers all the aspects of epilepsy, from diagnosis to investigations and management. And I will talk about management tomorrow. So have you all, do you all know about this course?
No, bro.
No, I see. I think it's only shared among the doctors, but it's actually open for medical students and trainees as well. Okay, so if you are not sure or if you can't join the course, I will try to record the videos of my presentation and I'll put in my YouTube channel for you to view. The next thing is if you want to read more, you can find the consensus guideline in 2017. This is how you do. You go to Malaysian Society MSN website, which is www.neuron.org.my, and then you click on the resources, and then from there you can find consensus guideline on the management of epilepsy 2017. So for approach to diagnosis, these are the steps that we have to do. The first one is we need to know whether this is epileptic or non-epileptic seizures, especially those related to syncope. Then if it's seizures, then you want to know whether they are generalized or focal. Then you want to know what are the etiology, and this is related to investigations that we are going to discuss today. And after that, we will decide what are the electroclinical syndrome based on various components in epilepsy. This is a very interesting paper in First Seizure Clinic. What we can find is that you realize of all the cases, which is 161 cases in First Seizure Clinic in UK, there are about 59 of them was diagnosed to have syncope at the end. Okay, so syncope is in fact a common differential diagnosis in First Seizure Clinic because they're presented with intermittent loss of awareness, and we are unsure whether these are seizures or these are in fact syncope. But there are two key points here. The first point is this: convulsive syncope is actually quite common. So what is convulsive syncope? Convulsive syncope is someone with syncopal attack end up with a convulsion. So what happened is after the syncope, patient develop seizure-like jerks, or they may faint and then having tonic posturing, and we thought those are seizures, but they are in fact an effect of syncope. The second point is, how do we tell whether a seizure-like episodes are real seizure or they are in fact convulsive syncope? Is to look for syncopal prodromes. Okay, so syncopal prodromes are things like sweating, giddiness, palpitation, which I will try to talk a bit more. Okay, so after we differentiate whether the patient see episodes is epileptic or non-epileptic, the next steps is to differentiate whether they are focal or generalized. So determining focal and generalized depends on the description of the seizure itself. But sometimes we are unable to tell because we see the patients at the end of the episodes. Patient may be post-ictal or patient may be generalized tonic-clonic, but we are not sure whether they are focal onset or not focal onset. So these are some of the things that is very useful for us to differentiate whether generalized seizures are focal or not focal. So the first thing is that you look for structural causes and investigations does matter, whereas generalized seizures are either genetic or metabolic or electrolytes like hypoglycemia. The reason why we differentiate focal and generalized epilepsy is because it determines what choice of medication we are going to choose, and then it determines the prognosis, how likely is it going to be responsive to medication, and then it also determines whether we need to consider epilepsy surgery at the end. So these are some of the tips. When we see a patient with generalized seizures, then there are certain things will help us to know whether it's likely focal or not focal. So let me go through this one by one. The first one, examination, if you find a focal weakness, let's say a left-sided body weakness after seizure, then this is TOTS phenomena. This is likely a focal seizure. Or patient develop hemiparesis with dysphasia due to stroke, then you also know that the stroke is causing the seizure, and that's why it is focal. Asymmetry is important. A lot of times patients develop jerks both sides, but if you ask them further, they'll tell you that the left hand jerk first, followed by the right side, rather than both hand jerks at the same time. Or if you ask them whether the heads turn to one side, they'll say, oh yeah, the head turned to the right side, the eyes look to the right when the patient having the jerks, which will tell you this is likely focal in origin. The aura is also important. When in the history, when we ask about aura, you will explain, because all aura are likely focal, except some rare occasions that aura is related, or non-specific aura is related to generalized seizures. So let's say patient develop visual aura, then you know this is occipital lobe epilepsy, and therefore it is focal. The next thing is neuroimaging. If you find a imaging which is focal, like having a tumor, then this, no matter what seizures they present, let's say they develop generalized tonic-clonic seizures, but you'll find a tumor, then the seizure is likely to be focal in origin. And the last one is age more than 20. So in summary, you need to get the details or tips from the history, from the physical examinations, from the description of the seizure itself, including aura, ictal, pre-ictal, ictal, and post-ictal. And the last one is investigations like imaging. So if you get a patient with hypoglycemia, and then the seizures appear to be one side, more on the right side, but we know that hypoglycemia can present with focal seizures. So it doesn't mean hypoglycemia are generalized in origin, but if you see a tumor in the scan, then it's likely to be focal. The reason why we pick the age more than 20 is because genetic generalized epilepsy, or IGE, we called it in the past, including childhood absence epilepsy, juvenile absence epilepsy, and juvenile myoclonic epilepsy. Most of them occur below 20 years old. So if someone having a generalized seizure for the first time after 20 years old, we know that they are likely focal, or more possibly a focal seizures. So the next one is etiology, which is related to the investigations that we are going to talk about today. So in 2005, epilepsy was defined as a disease with an enduring predisposition. What is enduring predisposition? It is any cause of seizure that is likely to occur or persist. Then it is an enduring predisposition. For example, a stroke. So a stroke with one seizure, we can call this an epilepsy. Or a patient with a tumor, or having an intracranial bleed, then with a seizure, then we know that these are likely related, and the patient is likely to have seizure again and again. So although the patient only have one seizure for that moment, is already enough to define as epilepsy. But this definition is incomplete. It didn't include the etiology. So in 2017, a new classification of epilepsies was proposed. It includes whether it's focal or generalized, or sometimes unknown, because some syndromes are both focal and generalized. But more importantly, it also lists down what are the possible etiology on the right side, including structural, genetic, infectious, metabolic, immune, and unknown. And for this reason, it helps us to understand that it is very important to identify the etiology behind the seizures. So in the past, when we see a patient with epilepsy, we only ask, hey, what types of seizure it is? Is it focal generalized? Then we also ask, is it due to stroke? Is it due to trauma? Is it due to hypoglycemia or alcohol withdrawal? So these are what we did in the past. But now, in the new era, we need a new approach to identify the syndrome. So it's no longer talking about what is the seizure types and etiology, but also to identify what syndrome it is. And to know the syndrome, we need to roughly know what is the age of onset, what are the seizure types, what are the provoking factors, what are the family history, cognitive development, EEG features, and imaging, and etc. So syndrome, if you can see in the chart, there are so many epilepsy syndrome. In brief, what it means is that epilepsy is not due to one cause. It can be due to many various causes, causing a similar syndrome or problem, which we call epilepsy, or clinically, we call it seizures. So I use two examples to illustrate how important to know the syndrome, because it helps us in terms of treatment as well as prognosis. So the two examples I'm using is juvenile myoclonic epilepsy, and the second one is mesial temporal lobe epilepsy, or MTS, mesial temporal sclerosis. So in juvenile myoclonic epilepsy, we know that the onset is juvenile age, especially when people going to secondary school from 11 to 17, 18. The features are mainly myoclonic seizures in the morning, especially when they are brushing their teeth and when they are eating breakfast. Suddenly they jerk. If you look at my video now, then suddenly you will jerk and they throw away their spoons and forks or toothbrush. However, a lot of times, if we don't ask, we won't know, because the patient presented mostly with generalized tonic-clonic seizures. They don't come to see you for myoclonic seizures. They come to see you for generalized tonic-clonic seizures. This JME is genetic in origin. We won't see anything in the scan, but the EEG will show a typical generalized polyspike and wave complexes. And these complexes, a lot of times, they are photosensitive. They are provoked by photic stimulation. So the key point about diagnosing JME is that they respond to sodium valproate. They aggravate by carbamazepine, and we cannot use carbamazepine because it makes it worse. And they have a high relapse rate. And therefore, a lot of times when someone, despite having seizure freedom for 2 years, no more seizures already for 2 years on treatment, but we know that they are likely to relapse. If we stop the medication, 70% of them will have recurrent seizure. And because of that, we will be very cautious or may not even consider withdrawing or stop the medications. However, mesial temporal sclerosis is another syndrome. You know that the onset of seizures can be at any time, but the semiology are very temporal lobe-like. What happens is patients will develop aura of fear, sometimes deja vu, sometimes they feel this epigastric discomfort, which going up towards the throat. We call it ascending epigastric aura. During the seizure, patient develop mouth lip smacking movement. We call it oral automatism. And a lot of times they have dystonic posturing of the hand contralateral to the lesions. So for example, the hands will be in dystonic posture. If you look at my video, now, is dystonic posturing. And this indicates that the lesions is on the contralateral side. So this is called mesial temporal sclerosis. If the lesion is on the left side, then the likely dystonia is on the right side. And what will happen to the patient is patients will be refractory to the treatment. A lot of times, even if you try many medications, patients' seizures is not controlled. And the good news is that patients can be considered providing surgery. And the surgery success rate is as high as 70 to 80%. So knowing the syndrome will help us to know what is the prognosis, what is the best treatment, what is the likely outcome of the medications, and what is the other alternatives that we should consider. And therefore, nowadays, we don't talk about purely focal or generalized epilepsy, and you don't purely talk about what are the etiologies, but we also go into the details of syndrome. All right, so now I'll start talking about investigation, but investigations will be very brief, but mainly for the medical officers or at neurology trainees who are going to train in neurology. So as I mentioned, in 2017, the etiology was classified accordingly. Let me go through, show you again. The etiology was classified as structural, genetic, infectious, metabolic, immune, and unknown. What is lacking in this 2017 classification is that they didn't divide epilepsy into acute seizure, in the old terms we use acute symptomatic seizures, or chronic or remote symptomatic epilepsy. What happened is that some of these etiology, they occur once, very transient, maybe last for hours to days. And then patient recover and they have no more seizures after that. For example, sometimes a seizure occur because of hypoglycemia. And once you correct the hypoglycemia, the seizure will be resolved. Or some patients develop encephalitis. And once the encephalitis is treated, the seizure will stop as well, except some develop post-encephalitic epilepsy. So what happened is that the chart just now didn't divide them into acute or remote or chronic epilepsy. However, for investigation in the emergency, we need to consider all possibilities, including those that I have mentioned. We usually don't look for structural cause unless the history is suggestive. For example, patient having an accident or patient having a sudden hemiparesis indicating stroke, or patient is having a fever indicating encephalitis. Otherwise, we'll do the blood screening first, and that's why investigation, we always focus on those who are blood related or blood investigations related. The first one, and those which can be quickly corrected, is electrolytes and metabolite screening, which we can do it quickly, just take a blood and screen immediately. Especially glucose, we can do dextrometer in the emergency straight away. Infections and immune screening will depend on the clinical scenario, whether patients develop signs and symptoms indicating infections, for example, fever, neck stiffness, impaired consciousness, or delirium. Whereas immune screen depends on whether there are symptoms of autoimmune encephalitis or autoimmune disorders like SLE. Otherwise, we won't screen the immune causes in the emergency. Other things, which is toxicology, are important causes, especially certain specific drugs. If you don't think about it, you may not realize those are the causes, or those are like the culprit for the seizures. And therefore, it's important to know what are the drugs that patients are taking. And a lot of times, patients develop seizure and come to emergency is because they miss their current medication. So a lot of epilepsy patients, when they stop taking or miss their dose of medication, or they cut down their dose, then they develop a seizure, and drug withdrawal is one of the common cause of epilepsy. EEG, lumbar puncture, and MRI will be much later. We cannot do EEG now in the emergency, but ideally we would want to do EEG for all the patients with seizures or suspicious seizures. All right, so I'll go through some of this detail in the case later on. So EEG is a brainwave monitoring activity. It includes putting a wires on the scalp according to certain coordinates. And this is like ECG. ECG is for the heart. EEG is for the brain. It's detecting electrical activity in the brain. And that's why it's called brain wave test. So in EEG, we can see discharges, and some of the discharges are very typical of certain syndrome. For example, generalized polyspike and wave are very typical for juvenile myoclonic epilepsy, and therefore EEG is very useful. However, we know that only 50% of people with epilepsy, when they first do their EEG, only 50% of them will have abnormal EEG. Another 50%, their EEG will be normal. The reason being, the seizure occur in between. And when we do the EEG, we are only capturing the segment of 30 minutes to 1 hour between the two seizures. And therefore, very likely or possibly that during that period of time, we are not capturing any abnormal EEG patterns. However, the EEG can be as abnormal as high as 50% is because despite having two seizures maybe 1 month apart, during the period, we will still see some small interictal activity. We call it interictal epileptic form discharges. Or sometimes there are just some small sharp and spikes, but it helps us to identify whether the seizure is focal or generalized. The next thing is scan. When we do a scan, we are looking for structural abnormalities. Certain structural abnormalities are very clear, very easy to identify. For example, stroke, for example, tumor, for example, bleed. But certain abnormalities are related to epilepsy, for example, this one. In mesial temporal sclerosis, we will not be able to see them in CT scan. We will need an MRI to identify the lesion. What you will see is in T2, you will see that the lesion is bright, especially here. This is a T2 flare. The lesion is bright because hyperintensity in the hippocampal region, and there is atrophy of the brain. So there is atrophy and hyperintensity are two pathognomonic features of mesial temporal sclerosis. And this is the hippocampus of the brain. This is the coronal cut, and you can see that this is the left, this is the right. The arrow is pointing towards the hippocampus. And this can be easily identified if you do the MRI accordingly to the epilepsy protocol. Focal cortical dysplasia can be very subtle. What happens is that many chronic epilepsy, if we do a CT scan, the CT scan will be normal unless the patient already have a clear-cut lesions, for example, stroke and tumor. Otherwise, we will not see any abnormal CT brain, or at times you only see cerebral atrophy, or you see multiple white matter changes, which cannot help in determining the etiology of the epilepsy. So we need an MRI. But as I said just now, MRI, in the first glance, it may look normal. For example, focal cortical dysplasia. This CT scan looks normal. But in fact, there are some abnormal changes that we are not aware if we don't look carefully. What happened is patient having a left version or left versive seizures when they develop seizures. So what happened to the patient is his head will turn forcefully to the left as you can see here, the head will turn forcefully to the left side. So can you identify whether this is normal and abnormal? Then you will start thinking, oh, is there anything wrong on the right side if the head turned to the left? Is there anything wrong in the frontal lobe if this is a version or this is a versive seizures? So you will see this. You'll see that actually patient have a abnormal brain cortex on the right frontal region here, which is here. It's not the circle that I draw here, but it's over the right frontal region, which explains the left versions in his seizures. So what happened is that MRI also has its own problem. A lot of times we only say that 30 to 40% of the MRI in epilepsy are abnormal, but in fact, the abnormality can be up to 70%. But some of them are very subtle. If you don't look carefully, if you don't analyze the semiology accordingly, you will miss the lesion. Sometimes we do additional analysis called voxel-based morphometry to identify the lesion, especially in this case. Over the right side, the lesion is very subtle. It's a bit just blurry. If you don't look carefully, we will not see. But if you look voxel-based morphometry on the left, then you'll see a very bright spot on that area, indicating that the brain structure is not normal. This is called voxel-based morphometry. It's using mathematical formula to analyze the MRI, comparing to the normal database. So now I'm going through the cases. You all feel free to answer the questions. These are all questions. And if you can't, just type your answer in the chat. So you can open your chat now. The questions are all in A, B, C, D, E in multiple choice. So you can type your answer in the chat so that I can see what do you think. Okay, the first question, elderly with confusions. And the patient is on carbamazepine. So you can type your answer in the chat. Do you find a chat? Group chat? So what is the answer? Carbamazepine now become confused. So what is the likely cause? A, B, C, D, or E? B. Okay, correct, huh? The patient is having hyponatremia. All right, so hyperammonia, will come to that later on, huh? But carbamazepine is commonly known to develop or to have hyponatremia. The thing is that many of them, their sodium is slightly low, but not causing any symptoms. In those cases, sometimes I would just cut down the carbamazepine slightly, or observing whether patient have any problem later on or not. For example, sodium of slightly lower than normal, we may not even have to correct the carbamazepine dose. How about sodium valproate? This is the same patient, but patient is on sodium valproate and develop confusions. Huh? Why a focal epilepsy on sodium valproate is because in elderly, sometimes we want to avoid side effect of carbamazepine and phenytoin. At times we try sodium valproate first, although this is not a good choice. But patient develop confusions with sodium valproate. So what do you think is the problem? Is it A, B, C, or D, or E? E. Okay, Mala. So C, C, C. Any other answers? C. Okay, huh? So this is related to sodium valproate, and we know that sodium valproate is commonly will cause hypoammoniemia, and that's why in these cases we need to check their ammonium, even though their liver function is normal. Okay, so hyperammonemia occur very commonly in patients with liver failure, alcoholism, and which can cause hepatic encephalopathy. But in sodium valproate, especially those who are given high dose intravenous sodium valproate and develop confusions, we need to consider checking their ammonia. This is the third question. Patients with stroke and muscle biopsy show record rate fibers. So it's very straightforward. It's a mitochondrial disease. And the disease syndrome is called MELAS. Mitochondrial encephalopathy with lactic acidosis and stroke, mitochondrial disease. Okay, so this patient developed seizure later because the stroke in the brain can cause seizures, all right? So he developed seizures 1 week later. There is one anti-epileptic drugs we should avoid. Which one? A, B, C, D, or E? Is there any anti-epileptics that we should try to avoid in mitochondrial disease? Okay, yeah, you are correct. The main medications to avoid is sodium valproate. Because sodium valproate may aggravate seizures or may aggravate the situations because it disturbs or disrupts the mitochondrial functions. The next case, bleeding. This is very rare, but for surgery, sometimes we need to consider, especially if epilepsy patients on drugs develop bleeding during surgery. Then we need to think whether it is due to the anti-epileptic drugs or not. So which drug is responsible for bleeding? Is it carbamazepine, valproate, lamotrigine, levetiracetam, or none? Okay. Yes, sodium valproate will affect the platelet function. So it will cause platelet dysfunction. Although it's not common, we seldom see patients on sodium valproate develop gum bleeding like in dengue, or develop bruises like in purpura. But during surgery, valproate can affect platelet function. So if there's a bleeding, instead of stopping the valproate, you may need to replace or replenish the platelet to stop the bleeding. So these are the side effects commonly related to medications, which we usually go through. But because I'm not talking about investigation, I'll just go through it quickly. But rather than asking you the answers, levetiracetam, although it's a very good drug, it can cause irritability, and it is common in young people, and it is as high as 30 to 40%. So a young girl become very quarrelsome, or always argue with their parents, or a young boy living or fighting or hiding themselves in the room. This can be because of the irritability secondary to levetiracetam. Whereas for topiramate, patients may develop naming difficulties. Zonisamide, I seldom see naming difficulties, although there are 2 or 3 patients which I thought is zonisamide. But topiramate is very common. Patient will have problem recall a certain words. Let's say you want to describe Mercedes, but he will just say, car, remember that day, the car, but I can't remember the name Mercedes. The next one is Stevens-Johnson syndrome. We know more commonly related to carbamazepine, but lamotrigine is also highly related. And nowadays, because we screen HLA-B1502, we have less Stevens-Johnson with carbamazepine, but we still have lamotrigine-induced Stevens-Johnson. The last one is zonisamide. Zonisamide has the same mechanism of actions as topiramate, but it has a known problem related to renal stone as well. So it's not only topiramate causing weight loss, topiramate causing naming difficulties, topiramate causing renal stone. Zonisamide will also have similar side effect, but less common or less frequent than topiramate. So the answer is A, B, C, D, or A, B, C, and D. All right. This is also investigation. I saw this young man many years ago. He developed a generalized tonic-clonic seizures. Then the emergency proceed to do a CT scan. As you know, in our emergency, between CT and EEG, CT is actually easier to be done. So he had a CT scan, and CT scan showed this, a young man, 17 years old. So what is the cause? Okay, so many of you has answered correct. This is basal ganglia calcification because patient has hypocalcemia. And later on, it was found to be related to hypoparathyroidism and developed subsequently a seizure due to hypocalcemia. So this is one of the straightforward, because the treatment is not anti-epileptic drugs, but the treatment is to correct the calcium and to correct the endocrine disorders. This is on another investigation and cause for seizures. Patient is a elderly with very severe backache. So he has tried many different analgesic drugs, but then he developed a seizure one day. Do you know which analgesic is he likely on and causing the seizure? Okay. So A, E, A, D, E. Okay. So what happened is gabapentin is used to treat the neuropathic pain. So sometimes we give gabapentin for backache as well because they have radicular pain. So E is not the answer. Mefenamic acid is an NSAID, non-steroidal anti-inflammatory drugs. Is for pain, but is also less likely to cause seizure. One of the common analgesic that was related to seizure is in fact tramadol. Tramadol was reported in many literatures to cause seizures, and in the early days, we thought it's related to high dose long-term tramadol. You must take 50 milligram TDS for at least 1 week to develop a seizure. But later on, people realized that even a low dose tramadol itself can cause seizure. So the answer is tramadol in the severe backache causing seizures. This is a very recent publications because the antibiotics is still very new. What happened is these are groups of elderly. They are found in the dialysis center or in the renal ward, patient with end-stage renal failure or chronic renal failure. And a lot of them develop confusion, encephalopathy, and some of them develop seizure, and their seizures become status epilepticus. So which antibiotic do you think is it likely on in end-stage renal failure and develop status epilepticus? So I see A, C, A. No one talk about B, D, and E. All right. So imipenem is commonly known to cause seizures, and that's why a lot of times if someone develops seizure or have a risk of seizure, we change the imipenem to meropenem. But imipenem causing seizures is not restricted to elderly, is not restricted to renal failure, is not only in this group. It can happen in any age and any condition, right? So imipenem can cause seizures, but not specifically in this group. So imipenem is not the answer. Vancomycin also can cause seizure, right? Vancomycin was reported to cause seizure, but also not specifically in the elderly with renal failure. So it's not A, it's not C. Okay, so let's choose again. Is it B, D, or E? Okay, B. Any other answer? Is it B, D, or E? B, cefepime. Yeah. So cefepime It's new. Huh? In the past, we don't have, when I was a houseman, there's no cefepime in the world. So cefepime neurotoxicity was recently described more and more. In some of the centers, they even have a cohort, a big cohort, and this is a systematic review on it. And you will realize that firstly, it caused the problem in the elderly, older patient, higher risk. Second, renal dysfunction, especially end-stage renal failure or chronic renal failure. And a lot of times when we do the EEG will show this generalized periodic discharge like GPET, and some of them has triphasic wave. So these are commonly described triphasic waves stimulation induced in cefepime related encephalopathy. So the answer is cefepime. All right, so the next one is management, which I'm not going to cover today. I'll only talk about it tomorrow if you are registered for the course. Otherwise, I will record the video and then I will put in my YouTube channel. Do you have any questions? Do you all have any questions?
Prof, morning, let me here.
Yes.
For the registration, before June 1st is a different rate.
It's actually no different because students registered yesterday is still the same rate.
That means the lower rate lah.
I don't know. Yesterday was okay. So I think they don't really mind. I don't think anyone has changed the rate.
I see. Because there are medical students also. If someone...
Yeah, that's why my student register using the lower rate yesterday.
Okay, all right, okay, thanks.
I think it doesn't really matter very much.
Okay, thanks.
So these are the principle of management that I'm going to talk tomorrow. So I'm not talking about it today. Okay, so I just give you a brief principle, but I'm not presenting today. All right, so any questions? If not, then I'll see you tomorrow if you are joining. Okay.
Thank you, Prof. Thank you very much.
Yes, thank you very much. Thank you all. Thank you. Bye bye.
Okay, bye.
Siapa? Toke tolong settle kan.